I'm very happy to be here today to present the results of the first year of a telegenetic support program in inborn errors of metabolism. Now, I know nobody here believes me, but this is a really exciting time to be in metabolism, especially if you listen to Mike Watson's talk. More than 1 in 3,000 infants are now diagnosed with a metabolic disorder by newborn screening, and particularly potentially treatable metabolic disorder. And there are a number of new diagnostics and therapies that are very much not only increasing the diagnostic rate, but improving the outcome. But there's always a but, isn't there? The supply of metabolic providers is not keeping up with the demand. Of those, maybe, I think it's between 300 and 400 people who are boarded in biochemical genetics. Only a fraction are MDs who are actively seeing a substantial number of patients in their clinic. Half of the metabolic clinics in this country are directed by physicians who don't have any specialized training in metabolic disease. So there's a provider to patient ratio of about 1 in 1,000, and it's getting worse. The patients just keep coming. And also, many adult patients have become disconnected from their pediatric providers. So we have a problem. We have a real problem. This is the newborn screening map from 2014, published in 2015 by Brad Thurl. And you can see that 15 years ago, these numbers of disorders screened for by state would have been 5, 6, 7. Now it's 48, 50, 54. It's going up and up and up, and there's no end in sight. But this is a picture of the number of physicians certifying in biochemical genetics. Now, the green circle is the year they combined it with molecular. Quickly, I think, saw the lack of wisdom of that. But you can see that it's really flat. We are exploding the number of metabolic disorders that we're screening for and diagnosing, and we're not training any more providers. Now, not only is this not good for patients, this actually isn't good for our providers. We are burning our metabolic providers out at a pretty rapid rate, and they're going off looking for other ways to contribute to metabolism besides direct patient care. I can't say I'm not guilty. So, trying to think outside the box. We saw the gaps, we saw the crisis, created the Genetic Metabolic Center for Education with a mission. We had a mission to fill some of those gaps, to educate and enable healthcare professionals worldwide in order to improve healthcare for children and adults with genetic metabolic disease. One part of this mission was to create a consultation and clinical support service, the CCSS. So this was obviously to address the gap in metabolic services, but also to develop solutions that would cross geographic and other boundaries, but in addition to educate. Because we've all heard, if you give someone a fish, you feed them for a day. If you teach them to fish, you feed them for life. And it's really the same in metabolism. So we didn't want to just be giving fish. We wanted to teach people how to fish. So what were the specific goals? Well, obviously to improve access to specialized metabolic expertise in diagnosis and management of metabolic disease, but also to provide support during periods of provider absences. Many metabolic physicians work in isolation, or even geneticists. They're the only one in their division at their med center. And when they go on vacation, it's a problem. I remember after the 2009 ASHG meeting in Honolulu, going on a cruise around the islands with my cousin, and my phone kept ringing at 3 in the morning because it was 9 in the morning in New York. And she was aghast, like, you can't even go on vacation? And I'm like, no. So we wanted to provide support so that if you are in a place without cell phone service on vacation, your patients are still getting support and you're getting relief. And then also to help metabolic clinics during provider vacancies, because sometimes it can take years when a metabolic physician leaves to refill that position. So this is a different kind of telemedicine service than has been described earlier today. This telemedicine service is not providing direct patient care. It's actually supporting you. It's providing service to providers who feel that they're in a situation where they want some specific metabolic expertise. So it's not intended to replace you, it's intended to help you and supplement you. And it's not intended to replace direct in-person metabolic care. So how do you pay for this? How do you get it started? The pilot for the CCSS, the funding came from the New England Genetics Collaborative that helped with technical development and provided 45 hours of free consultation to the clinics within the New England region. And some took more advantage of their free hours of consultation than others. So the services were individualized. Some were people who really were very uncomfortable taking care of sick metabolic patients and utilized the service a lot. Some who just needed a little help. They might be very comfortable with PKU and MCAD, but when hyperammonemic coma showed up in their NICU, they wanted a little help. And also, we've provided some coverage for vacations and staffing losses. Now, the intent is not to keep patients in a med center that's not equipped to handle them, but the intent is to help them to care for patients that they might not otherwise have been able to, so the patients don't have to travel long distances to get access to specialized metabolic care, or in cases where it really is out of range, to help get the patient stabilized for transport. We've done ad hoc and also scheduled assistance, some 24-hour emergency access, and every consultation is followed by a written summary. So right now we have 2 board-certified metabolic geneticists, Mark Corson and I. We don't yet have a full-time metabolic dietitian, but we have the availability of some dietitian. So how do you cross state lines? This was alluded to earlier. Telehealth services across state lines are improving. There are now 17 states that are in the intrastate licensure compact, and there's 2 more that have active legislation, including Pennsylvania. If you're licensed in one of those states, then you can provide telehealth services across state lines. Otherwise, you do have to then become licensed in that state. So there are still some licensure barriers to providing the telehealth. How do you ensure it? Even though we're actually consulting with and providing advice to providers and not directly to patients, I think it's important that this kind of service be fully insured. That note that we write could end up in a medical record. It could end up anywhere. Your name is probably going to be in that medical record. So we recommend insurance. Also, security is an issue, and yes, we had to go through more HIPAA training and to use HIPAA-compliant methods, and I think someone already alluded to that today. So it's also important to do outcome assessment and monitoring. The ways that we're working on doing this include client feedback and satisfaction surveys and renewal of contracts. But we're also evaluating the clients as well as they're evaluating us, kind of like Uber. Because we want to know if we're helping people to learn, if we're doing a good job with our educational component. And we want to also help by assessing patient outcomes, which is turning out to be a little more difficult than we thought. But if you look at the new NCC contract grant applications, you'll see that they're recommending smart monitoring which is specific, measurable, achievable, relevant, and time-bound. So let's look at the results from the first year. There were 161 individual contacts involving 67 separate consultations. Some of these were to discuss a single patient, some were to discuss multiple patients. Some involved only the physician, a few only the nutritionist, and some both. Now, 57 of these took place in our beta testing area of New England, 1 in Pennsylvania, and 9 internationally in the country of Georgia and Jordan. The vast majority took place in the University of Vermont, Boston Medical Center, Providence, Hasbro Children's Hospital, as well as the 2 international groups. So the most common reason for consultation was management. Another relatively common, maybe a third as many, was for diagnosis, and then again some for diagnosis and management. And there were actually 3 counseling sessions that took place. And with one center, we're now involved, or in the process of getting involved, in a research project to look at the effectiveness of metabolic consultation and reducing the cost of send-out testing. The diagnoses were pretty classic metabolic diagnoses: urea cycle defects, amino, mitochondrial, organic, fatty acid oxidation, lysosomal disorders, but also in some cases symptoms. So being called because trying to go through a differential in a workup for acidosis or hypoglycemia that might or might not end up having a metabolic diagnosis. The 3 parent counseling sessions, one was for an abnormal newborn screen for 3-MCC deficiency, one for OTC, and one for congenital lactic acidosis. And the families appreciated the experience of being able to stay local because it was quite a long distance to go to a certified, boarded metabolic clinic. The congenital lactic acidosis case was unique in that the child was never stable enough to transport. So we were able to help get the pre-mortem genetic testing done that would help this family to get a diagnosis. We've also done some coverage for clinical needs, including on-call coverage for 4 physician absences. And at one site, they recognized the provider burnout potential, and we now actually provide phone coverage for metabolic problems 1 week out of every month. So that instead of being on call 24/7, 365, that geneticist gets a week without metabolic phone calls unless there's something they really need to handle. So has this been valuable? We now have 4 centers that have worked with us because they want to continue this beyond the free beta testing period. University of Vermont, where that geneticist actually is very happy with the services, and Rhode Island. And we have 2 where we're in process, and again, it's interstate licensing issues that have slowed us up from getting these contracts executed. We also have contracts with a large rural genetic practice in Pennsylvania, the international, and we're starting now to work with the Mountain States region. So outcomes. This has only been going on for a year. Outcome gathering started in 2016. User comments have been positive. I couldn't run our metabolic program without the service, and education is the true strength. So hopefully we're helping to fill that gap. We have an N of 2 for performance evaluations. So not a lot of data here yet, but on a scale of 1 to 5, with 1 being the highest, it seems to be working. It seems to be providing what people need. So access in emergent or non-emergent, relevant and practical information, follow-up reports, education, and likelihood to recommend or continue using. We don't have much data on the impact we've made in patient care, and I think it was a little naive to think I would get more of this. There was one patient who had very unstable ornithine transcarbamylase deficiency, was in the hospital all the time, doing very poorly, and after a series of consultations and medical management changes, they were able to fix that and keep the child out of the hospital, and is doing much better. But most of the rest, you know, the doc said that it helped, but I don't have any data. I can't count number of hospitalizations, and so we're going to have to work on better ways to collect outcomes data. But in conclusion, there's a problem. We have a critical shortage of biochemical genetics providers, which is impacting the well-being of patients and providers, and the patients keep coming, the newborn screen keeps expanding, and the number of people we're certifying just isn't going up. But a metabolic telehealth service can successfully fill the coverage gaps, provide some coverage for vacancies and absences, and provide respite, particularly for isolated providers. So I'm hoping that we will be able to continue with this, and we'll be able to really make sure that no matter where you live, your geneticist has some access to some metabolic expertise when they need it. Thank you.